Hi there. I am coming to you from um, Louisiana with your next lecture because I wanted to get this done so that you guys aren't waiting on videos and I don't get back till Tuesday late. Um, we're jumping to respiratory because it fits better to do the second half of A&P or airway and ventilation after this so that it goes right into the intubation practice because that's more relative. Quick review of anatomy and physiology of the airway. Air comes through the structures of the upper airway, goes through each smaller and smaller bronchiole into each alveolar sac, where there is CO2 offloaded from the incoming blood, O2 onloaded onto the outgoing blood. Blood goes back to the heart. This is the only place in the heart that the pulmonary or that the veins carry oxygenated blood. And then at the other end of that exchange, oxygenated blood is carried to the tissues where O2 is offloaded, CO2 is onloaded, and then carried back to the heart. Um, Physiology. So to remember, because I know these two get confusing. Ventilation is the process of bringing air from the environment into our lungs and then taking the air in our lungs back out of the environment. Respiration is either external respiration, where the O2 and CO2 are onloaded and offloaded at the alveolar membrane, and internal respiration is where O2 and CO2 are onloaded and offloaded at the cellular membrane. So either one of those can have a problem, and the end result is that the oxygen from the atmosphere does not get to the tissues. These are the other structural elements and essential elements, and we will review those in detail here in a minute. So, like I said, a variety of problems can affect the pulmonary system's ability to achieve gas exchange. And this has to happen because it is not only gets oxygen to our tissues, it removes waste products from cellular metabolism. So, intrinsic factors, things that are inside the patient that we may or may not be able to affect, certainly can't always cure. Asthma, any obstructive lung disease like emphysema or COPD, cancer, and then things that block the flow of blood through the alveoli, like pulmonary edema or pulmonary emboli. Extrinsic factors, COPD and cancer that come from smoking, um, the severity of these respiratory disorders, and then indoor and outdoor pollutants. In addition to cigarette smoking, we also see welding fumes, grain dust, coal miners, and the black lung disease. Those types of things can interfere with the alveolar membrane. So, for our ventilation to be effective or at least adequate, first, our neurological control that is in charge of telling us when to breathe has to be working correctly, which is why we see abnormal breathing in head injuries. The nerves between the brainstem and respiration, so that would be if like the high C1 fractures that interrupt that nerve and people aren't able to control breathing, and even lower cervical fractures can affect that the strength of those muscles. Functional diaphragm and intercostal muscles. We have to have an opening for the air to get in. We have to have open alveoli for the air to get from the bronchi and bronchioles down into the alveoli, and they have to be functional for that air exchange to happen. So, anytime we're doing an emergency treatment, what we're trying to do is make sure that all of those pieces are in place and we are overriding any of them that's not working until we can get them to the hospital. So diffusion is the process where particles move from an area of higher concentration to an area of lower concentration, and this is how many things in our body move into the bloodstream or into the cells, and it's something that we can change to try to impact what gets moved. So if the O2 is higher in the blood, it will more easily move into the tissues. It will still move into the tissues if it's not a lot higher, like if they are hypoxic, but not as effectively. There's a formula and a law, and I think it's Henry's law, that the more gas you have over the surface of the liquid, the greater the amount of the gas that will move into the liquid. Um, so damage to the alveolar or capillary walls, and then the space between the alveoli and the capillary wall can fill with fluid because of things like pulmonary edema. So our first treatment is always to provide high concentration O2, and then if we can figure out what's causing the problems, reducing the inflammation in the interstitial space. So the law I can't think of. You want to administer high flow O2. Identify the underlying cause if possible, but as you can see this little list of problems, there's a lot of things that we don't have any control over. Our only intervention is high flow O2. Then we want to get them to higher level of care as quickly as possible. Now, perfusion, the circulation of the blood through the lung tissues. So this is the little delivery trucks that have to come through and pick up the oxygen and take it. So no matter how much oxygen we have in the alveolar space, if there isn't adequate blood flow picking it up and taking it to the tissues, it's still gonna not have enough blood flow, or I'm sorry, enough oxygen at the tissues. So you need enough blood to circulate. You need enough hemoglobin in the blood because 90, oh goodness, it's greater than 99% of oxygen is carried to the tissues bound to a hemoglobin. Less than 1% of it is carried diffused loose in the blood. So if you don't have enough hemoglobin, you are not going to effectively get oxygen to the blood. If the capillaries are occluded, the blood never gets to the spot where it needs to be to get the oxygen unloaded, and you have to have efficient pumping by the heart. Okay. Perfusion problems, the things that we can affect are minimal in the field. We can correct hypovolemia by giving an IV blood fluid bolus, which could potentially improve the blood flow by raising the blood pressure. Other than that, we don't give blood. We don't have any treatment for a PE, so high flow O2 is always high flow O2, and then a fluid bolus if indicated. So, care should be focused on the specific disorder. For us, ours is a little less focused, but this applies to emergency medicine in the ER where not every treatment gets the exact same, or not every disease gets the exact same treatment. But as you can see right here, once again, all patients with respiratory compromise, including people with COPD, should receive high flow O2 and ventilator support, which is bag valve mask, as needed. Okay, respiratory failure. So, respiratory distress, as we know, is what we see when the person is saying, I'm short of breath, visibly struggling to breathe, increased work of breathing with secondary muscles like intercostal retractions, high respiratory rate, gasping, sh uh, respirations, or noisy respirations. And then that eventually progresses to failure. And at failure, we are at the point where we have to intervene or this patient is going to die. So it's not respiratory arrest, but we're on the downhill slope. The key is to try to recognize it as at distress and intervene. If you're into failure, you have to be sure that you're watching your patient closely for these signs because people who are breathing 40 times a minute and kind of gasping, as they go into failure, their respiratory rate will slow down and they won't be quite so noisy and they won't look so distressed. And you might be tricked into thinking that they are going into recovery. But if you're looking closely, you're going to see that they're actually just starting to fail. Um, Low O2 sat, we'll discuss O2 sats because sometimes they can be false positives. Increasing in tidal if you have that on. They will become altered mental status, lethargic, maybe confused. You will start to see abnormal coloration of their peripheral tissues, and you might see changes in their heart rhythm. So, of course, primary assessment, immediate life threats. So, if they are breathing to some degree, then we don't need to immediately grab a BVM, but then we need to move on to our secondary survey and figure out what we do need to do. Life-threatening respiratory distress. Once again, alterations in mental status. This can be difficult to assess, especially in the elderly, because we don't know their baseline. You can ask a family, or you can always err on the side of caution and throw on some oxygen. Cyanosis, inability to speak one or two words in a row without gasping, taking a breath. Abnormal breath sounds. We're going to talk more about auscultation and how we should be doing it. And then patient position, we know the tripod position where people are leaning forward and like trying to expand their lungs, or even a patient that can't lay back and insists on sitting up in a high Fowler's position. So focused history, and this might be very short. If your patient is having trouble breathing, you can also ask a family or bystander. Chief complaint, focus history of this event. So if they have COPD, that's pertinent. If they had their gallbladder out when they were 20, that's not pertinent. If they have hypothyroidism, so does everybody. You just need to know what's pertinent to this. Medication if history, if they have it, and once again, if they take an aspirin a day, if they take a multivitamin, if they take a vitamin D, that's not what we need to know. We need to know that they use a steroid inhaler, or that they're on a prednisone pack, or that they're on antibiotics, or whatever is pertinent. Secondary assessment. Um, this is just a deeper look at all the things that you looked at to start with. If you kind of stopped with looking at how hard they were breathing and went straight to getting the mask O2 on, now you can take a look at their fingernail beds and pull off their shirt and see if they've got intercostal retractions. You do want a full set of vitals. This should include an end tidal. We need to be using that more. These can be the nasal cannula end tidal can be kind of tricky to use if people have a rapid rate. Um, This is just kind of a picture of that sort of tripod position. The barrel chest only occurs in people who have a chronic long-term respiratory illness. It's not a short-term assessment finding. Chronic disease was the barrel chest we were just talking about, or injury, because if this is a trauma, you have a different reason for them having difficulty breathing. Peripheral cyanosis, this clubbing of the fingers is something that we see with COPD and prolonged hypercapnia or elevated CO2. Pitting edema means that the problem actually starts in their heart and they don't have adequate blood flow, or I'm sorry, they don't have adequate fluid removal. And so not only is there edema in their extremities, there's probably edema on their lungs. And then carpal pedal spasm happens with a hyperventilation injury or situation where they drop their CO2 so low that you'll see in their hands and their feet this kind of a funky spasm where they can't control the movement. All right, so pulse oximetry. Pulse oximetry tells us how well the patient is being oxygenated, and this is a correlation between SpO2, which is the number that we measure with that little red light on the finger, and PaO2, which is the pressure of the oxygen. So PA is partial pressure of the oxygen in the artery flow. So you can kind of see here that if you're at 90%, you're at 60 millimeters of mercury of PO2. Normal for PO2 is 80 to 100, and normal for SpO2 is 93 to 98%. And if you have a question, well, you don't have to do NREMT, but if you're ever taking some random test and they ask a question about the amount, you want to make sure you're looking at which oxygen level they're asking for. Capnography is something that we can use to determine how much CO2 is being exhaled, and this can show respiratory status, but can also show other metabolic issues. This is sort of a really bad example or a bad tracing of what an end-tidal CO2 will look like. There's better ones further in the lecture, but as they breathe out, the reading of the CO2 rises and then it flattens off and then it drops back down. And that's when they are ending the breath, because in between breaths, there's no CO2 flowing out of their lungs, which is where the measurement's being taken. Back to this one, because I can't remember if it comes up again later. SpO2 measures the amount of hemoglobin that is saturated, and it is not able to determine what that hemoglobin is saturated with, whether it's carrying oxygen, carbon monoxide, or carbon dioxide. So that's why it's one tool that we have, but it's in a whole bucket of tools, and it's not the only one that we should use. So even if your patient has an entire SpO2 of 93%, if they tell you they're short of breath, if their fingernails are pale, if they seem confused, put oxygen on them and err on the side of caution. This is something they do. Testing your expiratory flow rate is something they do in like asthma testing. It's not something ever that we are going to do, so I'm not going to bog down on it. Thyroid diseases that often coexist. You've probably seen this already in your career. People can have COPD or emphysema and bronchitis, or they can have COPD and they'll say they have asthma. Sometimes it's kind of the treatments are similar, so I think people like to say they have asthma because there's less stigma, um, and they feel like I don't know. Anyways, smoking is the biggest pre-existing factor for COPD, but it is not the only pre-existing factor. So they tell you they don't smoke, it's possible they don't. And if they tell you they don't smoke, it's also possible they quit last week after smoking 2 packs a day for 40 years. And then acutely, there can be pulmonary infectious processes that then leave chronic damage to the lungs. Okay, chronic bronchitis. Characterized by an increase in number and size of mucus-producing glands. So this isn't the one time I got sick in the middle of winter and ended up being treated for bronchitis. These are people that get this like twice every winter, every single year. They're going to have a low oxygen level. They're going to have frequent respiratory tract infections like pneumonia on top of this. And then as these long, prolonged and repeated illnesses go on, they might have irreversible changes. So you can see this rather graphic little drawing here. The two problems that we see, three, inflammation of the epithelium, which reduces the size of the bronchiole, accumulation of mucus that can block the bronchiole, and then hyperinflation of alveoli when air gets past those strictures into the alveoli, but then can't get back out. The problem with that is that now new air can't get in to exchange, so that air no longer has oxygen. Emphysema, this is also COPD stands for chronic obstructive pulmonary disorder, and it's sort of an umbrella term that covers more than one problem. So emphysema and COPD are kind of used interchangeably. But permanent abnormal enlargement of the air spaces beyond the terminal bronchioles. These people, when they have what's known as an exacerbation, so COPD is something you have all the time. You manage it with daily medications and behaviors, lifestyle adjustments. They can then have what's called an exacerbation of COPD. They can just happen. They can be brought on by a respiratory illness on top of the COPD, like a cold or bronchitis. They their their personal treatment of what they try to do to make it easier to breathe is the same as an asthmatic, where they take a sharp breath in and then try to breathe out for a long period of time against pursed lips. We call it pursed lip breathing, because the air gets trapped and they are trying to get it pushed back out of their lungs because they can't exchange it for fresh air. That over time is what causes the chest to become barrel shaped. So that, like I said, is a chronic finding, not an acute finding. Um, this drawing, the first one on the left just shows you how air moves. I think it was kind of clear. And I'm not sure what that little protrusion is, like right there where that's sticking out. It didn't really explain that. Normal expiration, air moves out easily as the alveoli closes down. And since in abnormal respiration gets trapped, these little rings are muscle rings and they constrict. Now the air can't all get back out. So they have acute episode of worsening dyspnea even at rest, or sometimes it's brought on. If you've ever seen these people in a longer term setting, they'll like walk to the bathroom and then they'll come back and be really short of breath and it'll take them 10 minutes or 20 minutes to recover. And then one of the times they just don't recover. And then that's when they end up calling for us or going to the ER by private vehicle. Increase in sputum production would be adding an acute illness on top of their chronic illness. They're always tired because they have to work so hard to breathe. And they are also very thin because it's too much work to eat and breathe at the same time, and you have to breathe to live, so they don't eat. You might hear wheezes, that's the most common, and you'll hear rhonchi or crackles, especially if they have acute illness on top of it. So, we administer oxygen. Non-invasive positive pressure ventilation can both be a BVM with us providing manual breaths, or what's pictured here, which is a mask that straps to the face and connects to a machine that's programmed to give either CPAP, which is continuous positive airway pressure, or BiPAP, which is the same thing but with two different levels, like a higher pressure for inspiration and remain continues a pressure for on expiration. We don't currently have that capability. So the only thing that we would be able to do is to do it manually, which is why when we get to skills on this, we're going to spend a lot of time working on how to correctly BVM a patient. Because if we're doing it wrong, and most of us are, we aren't going to help this patient be better. Thorough medical history, you do want an IV line. You may or may not give fluids, but the hospital has medications that they can give through that IV. So just like in all of our cardiac patients and our trauma patients, we want the line in so that patient doesn't have to wait to get those meds. You want a cardiac monitor because there can be a lot of changes to the heart rhythm due as secondary to the respiratory problems. And then these are the medications that we give. Um, and I put this in my notes and now it's not showing. Beta agonists are albuterol, and nebulized anticholinergic is a drug called ipratropium, or the brand name is Atrovent. And there is a drug called a duoneb that is those two drugs combined. So we don't carry it. We just don't give albuterol often enough right now to justify carrying a second med that's also going to expire every 6 months. Depending on down the road, we may add it or we may also just exchange it because any patient that is a candidate for albuterol is also a candidate for duoneb. On to asthma. These people also use albuterol or duoneb. So they're usually born with it, and then it can be exacerbated if they are exercising, if they are exposed to like an allergen, a cat, flowers, whatever, or they develop a cold or some other acute on chronic illness. Typically, these asthma attacks are not self-restricting. The patient has to take some kind of a bronchodilator, or there are some, you can give like magnesium IV. They have to work a lot harder to breathe, and so they end up wearing out. With asthma, you don't want to intubate unless you have absolutely no choice because it's very hard for them to get off of the ventilator. But if they're wearing out, if they've been struggling for 2 hours and they're just tired and they're starting to slow down because they can't keep up this pace, you have to intubate because otherwise they're going to die. But your preferred treatment is to get out your O2, get out your Atrovent or your albuterol, get a continuous nab on, and let them, you can also start IV fluids, we'll talk about that later, and help them maintain where they're at or possibly even improve while you are rapidly transporting them to the hospital, which has even more things to give them, like IV steroids, to help them get through this acute exacerbation. Um, Other things that can happen, you can get fluid buildup in the um, like pulmonary edema. That's not that common. Lobar atelectasis is where all of um, the alveoli, I couldn't think of the word, alveoli in an entire lobe collapse and it's not able to use. Pneumonia is, they're more prone to pneumonia because their lung tissue is not as healthy. Tension pneumo can actually happen as a result of an asthma exacerbation, just from the extra work of breathing and part of the lung collapses. Obvious respiratory distress, check their mental status. Obtain an initial history. You are not going to get this from the patient, probably, but have they previously been intubated? That puts you on a little bit of high alert of how serious their illness is. And I like this may be noted. The prolonged expiratory phase will be noted. A normal breathing person has an IE ratio. So I inspiratory, E expiratory, and the ratio is how much time you breathe in versus how much time you breathe out. And normal relaxed respiration is an I to E ratio of 1 to 2, 1 to 2.5. So if you breathe once every 5 seconds, you're breathing in for about 1.5 seconds out of that, and you're breathing out for about 3.5 seconds of that. They are breathing in for 1 second or less, and then they are breathing out for 4 seconds. Asthmatics have IDE ratio typically of 1 to 4. When we put them on the ventilator, we set them with an IDE ratio of 1 to 4. So they will breathe out much longer. You typically hear wheezing. And then the capnography waveform has shark fin. So that's something when we see the waveforms, remember that. So the two changes in asthma, the alveoli gets air trapping, so it's hyperexpanded. And then this lining of the bronchioles, these little muscle bands, you see those pink things, those are muscle bands, and they constrict. And so the air, there's not enough room to move the air out. And then this very inner lining of the tubes gets inflamed and thickened. So we give oxygen, we give albuterol. Corticosteroids are not available in our setting, but they are in the ER. Nebulized magnesium sulfate, we do not have this. But magnesium is a smooth muscle relaxer. You may have seen it used in the many complications of pregnancy, like preterm labor and eclampsia, because it relaxes smooth muscles. Um, and so that's why it's used in asthma. Those muscle rings on the bronchi that are constricted and won't relax, they are smooth muscle. Non-invasive positive pressure ventilation, and if your patient is awake, which hopefully they are, you have to match their breaths. You trying to push a breath into them when they're trying to push a breath out is not helping them, their respiratory status, and is exacerbating their anxiety. IV fluids, and so this is that thickened lining of the bronchioles that can have mucus buildup. If you thin that, it's easier for them to clear it out. So that's part of the rehydration. The other thing is that they are systematically dehydrated typically because when you can't breathe, you don't take time to take a drink. When every time you breathe out, you know this from wearing like a ski mask. Every time you breathe out, you lose a little bit of like fluid in that like fog that comes out and fogs up your glasses. So when you've been breathing 40 times a minute for the last hour, you've lost a lot more fluid through respiration than you normally would. Position of comfort as always, and advanced airway management only if indicated. Status asthmaticus is prolonged asthma attack, even though we put them on a continuous neb and they still are not coming around and it's been 30 minutes and this would be like at the hospital. We've also given all the other things. This is something that would possibly require ventilator support. Asthmatics can sometimes, well, asthmatics frequently treat their minor asthma attacks at home with a rescue inhaler. That's why they always carry an albuterol everywhere they go. They usually take a daily medication as well, and as long as they stick to their medication medication regimen and don't get any triggers, they're usually okay. This is something that is falls outside of that. Okay. Wheezing is common with asthma, but you may hear it in other diseases. So just because they have wheezes does not mean that they have asthma. Emergency care based on patient assessment and accurate history. So if you are dealing with a child who's asthmatic, ask the mom, like, what happened last time? Or what do you normally do? And or ask the parent. They can tell you kind of what works best for their kid. It's the easy way to figure out what's going on. These slides about COVID, I felt like were a little outdated. I'm glad they're adding stuff, but this virus has mutated quite a bit since it first appeared, and it's less virulent and does not cause the same I haven't seen the same respiratory pattern as I did when I watched all the people die of COVID. Um, but it's spread the same way as all of the respiratory viruses. It then this COVID caused other complications besides just respiratory. So that was kind of the weird thing. It caused a lot of like circulatory disorders, blood clotting, and inflammation throughout the body. So some people that had it didn't even really have respiratory symptoms, or if they did, it seemed like a mild cold, but then they showed up with having other problems later, neurological problems, circulatory problems, GI problems. So if we're still testing for it off and on, and people get kind of concerned, like, oh, they're positive for COVID. But I know a lot of people that probably had it and just thought it was a cold. I know people who are getting influenza because, of course, everyone stopped getting vaccines, and I see them get way sicker with influenza than I do with COVID. So the management is the same. You still put on oxygen. With COVID, when it was so easily spread and we didn't know how it was spread, and it was so virulent, we put masks on because then as the patient was breathing out and sending out all these infectious droplets, they were getting trapped in the mask. We also didn't do nebulizers because you know how that stream of the like smoke looking stuff that contained their infectious droplets as well. Um, if intubation was required, we try to avoid intubation as long as possible because unfortunately, once you got intubated, it was very unlikely to be recover. Okay, pneumonia. This can be viral. Viral is probably the most common, bacterial or fungal. Productive cough, and by that means thick yellow or green sputum coming out of the lungs when they cough. Pleuritic chest pain. They may breathe faster. You will hear crackles or rhonchi, or both, and they can have a fever, but not always. This is just showing a little drawing, but pneumonia can establish in just one lobe of the lung, and so you might hear the rhonchi in one lobe, but not all of the lungs. Viral pneumonia is most commonly caused by adults, influenza in adults, and RSV in children. Bacterial pneumonia is the one that um, we take at age 50. You're eligible for the pneumovac vaccine, so we don't have as much of it. Um, the mycoplasmal pneumonia, these are basically they're named after whatever bacteria caused them. This one is incredibly uncommon. These are people who have usually an environmental exposure to something that's damaging to the inside of the lungs. Aspiration pneumonia, however, is very common, and it's frequently um, occurs in people in long-term care or prolonged hospital stays, which makes it then a nosocomial infection. So it's called, I'm trying to think of the acronym, healthcare acquired pneumonia, HAP, and then CAP is community acquired pneumonia. This is a big deal if you have a patient who's in the hospital or a family member and they end up with pneumonia once they got there. That means we did something as healthcare providers that allowed them to aspirate or directly caused them to aspirate. And so we sort of did this to them. It's a big deal because people come to us to get better, not worse, but it's also a big deal because payer sources refuse to pay for the hospital stay because the hospital made them sicker and they aren't paying for that. So then admin gets pissy because they just lost $40,000. Um, so aspirated foreign bodies. This is like people who have trouble swallowing and we're feeding them and they end up getting some of their oatmeal into their lungs instead of all into their stomach. The inside of your lungs is pretty close to sterile, and any bacteria or viruses that get in there, the lungs are quickly able to get it back out. However, a chunk of oatmeal or repeated your milkshakes going into your lungs, it can't clear that out quickly enough. And so now you have this non-sterile, full of bacteria with sugar that has a source for it to grow. inside the lungs where it just starts to go haywire because it's a warm, dark, moist place, which is exactly where bacteria and viruses love to go. So you can look for the causative agent. They would do that and when these patients cough up a chunk, they catch it and they test it to see what it's growing. They can also draw blood to try to find out. Same things usually as regular pneumonia, chest pain, cough, fever, difficulty breathing, general malaise. You might hear wheezing or fine crackles. Back here, hemoptysis is coughing up blood, and that's very rare with pneumonia. Um, Bacterial pneumonia, low blood or low SpO2. You might have a high heart rate or high respiratory rate. And then a cough with production of sputum that's usually thick. Yellow and green are the most common um, colors. So the first sign we see for even the risk of aspiration pneumonia is that the patient coughs frequently, especially after eating or drinking. This also can happen with a ventilated patient because that ET tube goes past the epiglottis, which is our normal protective mechanism that keeps liquids from going into our lungs and stuff into our esophagus. And even though it technically occludes it with that balloon, it's not a watertight seal. So then oral secretions pool on top of that balloon, and then every time the patient moves or whatever, some of that leaks around the cuff and into the lungs. You might hear abnormal lung sounds, cyanosis if you haven't been giving them adequate supplemental oxygen. Sepsis, you can develop sepsis or septic shock from pneumonia, but it's not automatic. You can also treat the ammonia aggressively as soon as it's diagnosed. So the some of the risk factors or some of the signs that should make you concerned for sepsis is increased heart rate, increased respiratory rate, increased temperature. And remember, blood pressure, low blood pressure is a late sign in septic shock. So in early septic shock, you will still have a normal blood pressure, but you will notice prolonged capillary refill. Provide airway support, O2, ventilator assistance as needed. The IV fluids, once again, support blood pressure, but to thin and loosen mucus. And you want cardiac monitoring and evaluation by a physician. ARDS is a group of, well, it's a syndrome. And so it can be caused by a lot of different things, but it is, if people go into ARDS, it's very difficult to recover from. I remember the number was like 70%, only 70% of people that go into ARDS live. Um, so pulmonary edema, this is a cute little drawing of a waterfall into an alveoli. But what that in talking about is that there's a whole bunch of fluid inside the alveoli, and wherever that fluid is, air is not moving to have exchange of O2 and CO2, which decreases the amount of O2 going into the blood. Atelectasis is the collapse of an alveoli, which means it is then not working. And then this cute little picture of macrophages, are the cells that attack bacteria and viruses and kill them. I'm assuming they're showing you that they're enlarged because they're on overdrive. Replace fluids that are lost. Um, Drug therapy to support mechanical ventilation means that if you're on the ventilator, you're going to need sedation and pain medication to be able to tolerate the ventilator. If you need to give something for blood pressure, that's something that would be done in the hospital. Diuretics, this is kind of funny because you replace fluids, but you also provide a diuretic to get the fluids out. So I think that probably depends on which problem the patient is having. See if you can find the underlying cause, which would be the organism, and treat it. High flow to in our environment and ventilator support in the hospital. Pulmonary embolism. We have learned about this. This is when a clot forms in a large vessel in a vein, to usually in the leg, and then breaks loose and travels through the heart and then travels to the lungs. And as it gets closer or into the smaller and smaller arterioles, eventually reaches a point where it's bigger than the vessel and it can no longer pass. All of the lung tissue behind that blockage is no longer getting blood flow. Sudden death is the first sign in about 1/4 of the patients. So those are the ones, we're going to show up. There's not much we can do. I had a coworker actually that died of this. She was at work. She said, I don't feel very good. And she sat down and she slumped over. She was working in the ICU in the hospital. She immediately got coded by the highest level of care, and they coded her for 45 minutes, and they never got her back. And on autopsy, they found this. So I mean, you couldn't find a better place to try to die, and this still killed her. So in this drawing, you can see that like the entire right lower lobe is not getting any blood flow. Um, this is the factors that can I don't know how to say that guy's name. Factors that contribute to clot formation. Hypercoagulability is something, usually stuff that we have no control over. It happened with cancer, it happened with the oral contraceptives, more so in the older generations of that. It can happen with pregnancy. Some people are just born with a coagulation disorder called factor V Leiden, and they just clot when they don't need to. Vessel injury, this can happen from most commonly long bone fractures, fractures of the pelvis, and then surgery, major surgeries. Venous stasis, this is the one we can impact. People should not sit for long periods of time. They should not be in bed for long periods of time. If they absolutely can't get up and walk or flex their feet and squeeze their legs, they have these devices that are put on their legs that pump up periodically and squeeze the blood back to their lungs. Flexing your muscles pushes on your blood vessels and pushes the blood back to the lungs. The way the clot forms is blood isn't moving very fast in the veins of your legs, and blood is sticky. So it likes to stick to anything, and it likes to stick to itself. And if it's not moving very quickly, think of a very slow moving river. It can catch and start to clot to itself. And then once a clot attaches to the wall of the vessel, or if there's damage to the wall and the cells start to clot there, then they really start to pile up like a log jam in the river. However, if the blood is moving briskly, the vessel or the cells don't have the chance to stick to themselves or to stick to anything, and they move through quickly. So it's sudden onset, occasionally coughing up blood. They're going to feel panicky. They're going to feel like they can't get a breath. They might feel chest pain. They are going to immediately have probably increased heart rate, increased respiratory rate. I don't know about a fever. The distended neck veins is the same thing with the tension pneumothorax. The blood that's trying to return into the chest isn't able to because there's not adequate blood flow out of the heart, which means there's not adequate the blood flow before the heart gets backed up, and they'll see hypotension or even syncope because the inadequate blood flow out of the heart is not getting enough blood to the tissues. We give them high flow O2 and we get an IV while we're en route because there's nothing we can do in the field except get these people to a higher level of care. They have to get an IV drug. There's a couple different drugs that they can get to help the clot break down. URIs, this is our common cold sinusitis. We have all had them. Um, if you already have a pulmonary condition, it can get worse when you catch a cold, which is why when we're sick, we all still go to work and get our coworkers sick, but we don't go visit grandma and we don't go visit brand new babies because they cannot tolerate this as well. We shouldn't go to work either, but yeah. Sore throat, fever, chills, headache, we all know this. Facial pain, sinuses, and then you can have green nasal drainage. Here's the key to nasal drainage. Clear and thin is allergies. Thick and yellow is a cold. Thick and green is a sinus infection. That's a typical pattern you'll see. So that purulent is not pus coming out of your nose. It is green sputum. Bad breath, cervical adenopathy, which is a fancy way of saying that these lymph nodes in your neck are swollen, And this is an even fancier way, erythematous pharynx. You know, you look in the back of your throat and it's red. That's what that means. Pre-hospital care is my land till you do not need to go to the hospital. However, relief symptoms, sore throat drops, Advil or Tylenol, um, and if you have an underlying infection or symptoms continue for longer than 7 days without at least starting to recover, you need to go in. You can have, I'm just throw this out here just because I thought of it. You can have a secondary infection. So one time I had a really bad cold. It went around work because people came to work even though they were sick. And I was, bad, like spots on my throat, just horrible body headache, body aches, can't take cold medicine, so I couldn't sleep. Um, and then it got better. And I went back to work. And then about 4 days after my initial illness, I suddenly started getting a really bad sore throat. And right on one side, just something stabbed me every time I tried to swallow. And I was taking Advil around the clock and it wasn't controlling it. And I knew that a secondary infection had set in and that it wasn't going to get better until I had got to the hospital or until I got on antibiotics. So I went in and sure enough, they gave me antibiotics. I was better within the first 3 doses of antibiotics, because all of that inflammation and mucus had created a place for a bacteria to grow. And so sometimes if somebody gets sick and then they get a little better and then they get sicker again, it's a secondary infection. Spontaneous pneumothorax. So I don't know what causes blebs, but when a bleb ruptures, um, air enters the pleural space. They can also happen spontaneously. Now, this is different from a tension pneumothorax. People can just have part of their lung be collapsed. They might be short of breath and they might like feel chest pain or have be breathing faster or even have an increased heart rate, but they are not going to have what we call hemodynamic instability, and that's when a pneumothorax becomes a tension pneumothorax. Um, and we'll talk about that in a minute, but remember that there's two kinds of pneumothorax. This is the simple one. Um, Severe case of a pneumo, though, can still require treatment. Um, Decreased breath sounds on the effective side. We don't do percussion in the field. Subcutaneous emphysema is what they meant to say. This is where you can feel and you feel the little like Rice crispy, bubble wrappy, crackly feeling. This is kind of funky to feel if you ever get a chance. Um, you do treat a pneumothorax the same way. You put a chest tube in and get the air out so the lung will re-expand, but we don't do that in the field. Our needle thoracotomy is only used in tension pneumothorax. We just give them high flow O2, circulatory support if needed, and if a tension pneumothorax develops, we perform needle chest decompression. And the difference is hemodynamic instability. If their heart rate goes to 140 and their blood pressure goes to 80 over 40, now you need to needle their chest. Hyperventilation, this can be caused most frequently by um, anxiety or some kind of psychogenic cause. Um, these are the things that it causes. The paresthesia, which is numbness and tingling to the legs. So if somebody's anxious and they're hyperventilating, and then they realize that their hands and feet are tingling, or they can't feel them, or their hands spasm and they can't move them, then they just get more anxious. If we can't talk them down, we can try. Um, we have to get them some kind of a sedative anti-anxiety so that it's just a spiral otherwise. Other things can also cause it. Certain metabolic disorders, most notably diabetic ketoacidosis, causes hyperventilation because the body is trying to balance the acid and base level to get the pH back to normal by blowing off CO2, which is an acid, because there's too much lactic acid. And so the body is acidotic, so it's trying to balance that. Neurological disorders, once again, the breathing respiratory center is in the brain. Wrong way. So difficulty breathing, rapid breathing, high minute volume, face tingling, carpal pedal spasm. Okay, so management. Supportive care. If the patient is awake and responsive, you can calm them or try to and help them slow down their breathing. They used to have people breathe into a brown paper bag. That's what that was supposed to do. It doesn't, the brown paper bag had nothing to do with it. Gave them something else to think about. So then they stopped gasping for air and focusing on what was making them panic to start with. However, if your patient has altered mental status and you're getting out of BVM to try to help them, you do not want to bag them at 12 breaths per minute if they were breathing at 30 breaths per minute because they were compensating for some other problem. And if you slow them down to 12, now they're no longer compensating. We used to kill people by intubating them because when you do an intubation in the hospital, you give a paralytic. So now the patient isn't breathing at all on their own. We are breathing for them. So people would come in and they would be breathing 30 times a minute. Oh, they're in respiratory distress. Oh, they're going to failure. We better intubate them. We never checked a pH before. We just intubated. Well, they had a pH of like 7.2, and the only reason they were still alive is because their body was throwing out CO2 as fast as it could to try to balance the pH. So we would put them on the ventilator, breathe it 12 times per minute, and within an hour they would be dead. And I saw this multiple times. We called it death by RSI. Um, because now their pH was 7, which is not usually compatible with life, because we took away their body's own compensation. So if you're not sure what or why your patient is breathing fast, if you're starting to give ventilations, you need to match their ventilatory rate. If they were breathing 30 times a minute, you need to breathe at least 20 or more times a minute for them. As always, you want to transport them if this is severe. So the reason it says this, because you're like, we transport everybody. If the patient is just anxious about something and you're able to talk to them and calm them through that, they can, if they've recovered, refuse. However, I have also seen the paramedics get call right back because as soon as we left and we were no longer there to calm them, whatever it was that was making them panic was still there. And so they hyperventilated again. We were back there within the hour and we ended up transporting, I think just because we knew it was going to be an ongoing case. Lung cancer typically evolves in older people because it's typically caused by an environmental, um, some kind of, what am I trying to think of? Like carcinogen. It's not, it doesn't have the genetic factor like colon cancer and breast cancer do. New cases, most patients die within 1 year. I think part of that is that people don't get diagnosed early because they either don't go in or they don't think that it's a problem. So these are some of the other risk factors that can increase your risk. So what happens is one tumor or more, but the tumors grow, cancerous cells grow at an abnormally fast rate. And so the tumor takes out the part of the lung that it's grown into. If it grows across a main airway, now all of the lung behind that is not getting oxygen. Treatment depends on the type of cancer, which is determined by biopsy that and radiation or usually chemo to try to shrink the tumor. They can also take the tumor, try to take the tumor. I had a great uncle that actually just didn't have one lung. His was not smoking, but he had a large tumor in one lung, and this was decades ago. They just took his lung out. He lived the rest of his life with only one lung. Different pictures of where the tumor could possibly grow. This third one over is showing you that it can develop in just the lung tissue and not on the bronchi or bronchioles. Cough, hemoptysis. I guess some of this stuff kind of onsets slowly. And so people are like, oh, I notice I have a little cough. And I'm like, it's a little worse. And we've all probably had some kind of a chronic illness that by the time you finally went in, they're like, what do you mean you are coughing up blood? And they're like, oh, how long has this been going on? I'm like, well, 6 months because they keep thinking it's going to get better. They don't realize that it's getting worse than it is. So for us, we're going to provide oxygen and we're going to take them to the hospital. Um, we analgesics, they can have a lot of pain depending on the stage. If they're diagnosed with lung cancer and we know they're end stage, um, we need to check for advanced directives, but we do need to provide them pain medicine. This will be an option for us shortly. And so, it is painful in the end stages, and so we need to be considerate of that. Respiratory failure, um, this is just the general term for when they are no longer able to compensate for whatever was wrong to start with other systems to try to make it so that their tissue is getting enough oxygen. So hypoxemia is inadequate oxygen in the blood. It can be caused by all of these problems here. I'm not going to read you the sign. VQ mismatch is what happens with a pulmonary embolism, where part of the circulation is blocked. So oxygen is getting into that alveoli, but no blood is coming by to pick up the oxygen. Hypercapnia is when they have too high of end tidal CO2, which happens when they are not moving air adequately in and out of the lungs. So these are things that happen more in the lung and not so much in the circulation. Okay, so that is the end of that lecture. Boy, that ended kind of abruptly, didn't it? Okay, so those are the basic lung diseases, and the next lecture will be on, we'll go back to airway structures, and then we'll just segue right into intubation.